All right. Well, hey, everybody. Welcome to HWL Talks. My name is Trevor Strauss. I'm the Senior Vice President here at HWL. And this is our podcast where we meet with leading healthcare innovators and leaders from across the country. Today, I'm fortunate enough to be joined by Dr. Josh Hargraves from ApolloMD. I've gotten to know Josh over the last few months, and we've had a lot of great discussions about a lot of different things within healthcare, and I'm excited to have him here today. Josh, before we dive in, why don't you introduce yourself, tell the audience about your journey, kind of from the bedside all the way up into the C-suite, and we'll go from there.
Awesome. Well, Trevor, thanks for having me. I really appreciate the opportunity to join you and continue the dialogue. It's been nice to meet you over the last several months. So I'll give you a little background about myself. So Josh Hargraves, emergency physician, also Divisional President for ApolloMD. We are a physician services organization that partners with about 130 various emergency departments, hospital medicine programs, small amount of anesthesia and radiology as well. I'm responsible for 25 of those locations, primarily in Georgia, Illinois, and Massachusetts, so kind of all over the place. A little bit about me, grew up in the DC area, went to college and medical school in North Carolina, UNC Chapel Hill for undergrad, and then Wake Forest for med school, and then did residency in Boston, and was there for 4 years, moved to Atlanta in 2009. And have been in Atlanta since that time. Was originally on faculty at Emory and Grady for several years, and that's sort of where I developed my interest in sort of hospital operations, emergency department operations, and then moved over to Piedmont in Atlanta for a little bit. Also worked at Northside for a little bit, so kind of covered all of the systems in the Atlanta market, and then joined ApolloMD in 2017 as a site medical director and sort of regional medical director, and have sort of grown from there and just increased my responsibilities along the way to now my current role. And excited to be here and have a conversation. So.
Yeah, no, I think it's great. I mean, I hearken back to when we first met with Health Connect South, and we were talking about a lot of things during that panel. One of the things that really struck me that you said was healthcare is hard. And there was a few different areas where you meant that. So let's kind of start there. Let's unpack that idea a little bit about healthcare is hard, not just from a clinical perspective, but also from the patient, from the operational, all the different things that you've seen.
Yeah, I appreciate you bringing that up. I mean, I think, I've been doing this for 20 years now, and I think the more I've interacted within the system, the more I've realized just how real difficult it is to deliver care on a day-to-day basis. When you really sort of look at healthcare overall, the regulatory environment is complex. When you think about sort of becoming a physician or a nurse, right? The amount of time and training and dollars that goes into that it's expensive, and it takes a lot of time to train clinicians and nurses. Hospital operations are complex. Just getting a patient to and from, one end of the hospital to the other after they've been in the emergency department takes a whole host of, people to be involved. And I think probably most importantly, the actual care delivery itself, right, is mentally, physically, and emotionally challenging. It's not, it can be difficult to be a clinician or a nurse or someone who's involved in patient care at a hospital. And I think when it all boils down, it's really, it's human beings taking care of other human beings. And that is a very challenging thing to do, and I don't think we always acknowledge that that's what it really comes down to. Right, at the end of the day, it's just another human taking care of another human. We can probably dive into this a little bit, but I think one of the comments I made that I think is true, and I've thought this throughout the years, which is like that part of healthcare that just the individual doesn't scale. Right, that's not something that just easily translates to a technology-based solution. Right, there's no technology solution for walking into a patient's room and delivering bad news. Right, and that's hard. And that's what I think I mean by that, right? Is that piece of it is just challenging.
Yeah, well, you shared with me, it really leads us into a great thing that you shared with me a little while ago is this Time article. And it's from about 30 years ago, if I remember correctly. And it was talking about the challenges of the ER then. And it's shocking that it hasn't really changed. So do you want to talk a little bit about that? Because I know you've got some thoughts and feelings around that article.
Yeah. It's funny. I remember that. So when I was a kid, we used to get Time magazine all the time, and I used to look forward to kind of opening up, reading about what's going on. And there's certain, I think, issues from Time that I still kind of have memory of, like sort of flipping through. And I was on a shift recently, and it was just there were patients kind of in the hallway everywhere, a lot of flu. Kind of a chaotic shift, which is not surprising in the emergency department. And for some reason, that article, that cover itself popped into my head. I didn't remember the article. So I went back and found it in the Time archives and started reading it, and I was floored. I mean, everything that they talked about in that article is still going on today. Boarding, patient boarding, malpractice issues, patient violence, lack of primary care resources. I mean, there were other things in that article but it could have been written today. And frankly, you could go and visit the same emergency departments that you visited then and write the exact same article. And I just reflected. I was like, if the problems are so intractable that it's been 35 years, that then this isn't it's not just a healthcare issue, right? There's more to it. There's some societal choices that we've made that have made it, I think, again, have made these problems stick around and are hard to deal with. I think it really sort of goes back to what kinds of things are we willing to do as a society to fix those? Because I don't think you can look at the healthcare system and say, hey, fix all these problems, because I don't think they're all the healthcare system's problems to fix. And so that, I think that it was a really eye-opening article to reread, and I certainly would encourage your listeners to go take a look at it for sure.
Yeah, we're going to put a link in the show notes for it because it floored me too. I mean, obviously this week we've had another shooting in an ER, and these things happen, right? I mean, I know they're not even reported on as heavily at different times, but the reality is this is a human business, if we want to call healthcare a business, right? And you and I have had some chats as we've been getting to know each other too about technology or AI and ambient listening and different things, because we do need to find ways to augment the human piece of this, because you're right, human portion of healthcare is not scalable. That going in, delivering bad news, being able to work with the patients, frankly, as an ER physician, being able to deal with everybody from the emergent situation to the psychiatric situation, et cetera, you can't really speed that up. But you have, over your 20 years, obviously noted a lot of different changes. You've seen new tools come into play and things like that. So why don't we talk a little bit, though, about the ways that we are working? And we can focus, of course, within emergency medicine, et cetera, but we are working to try to improve and maybe at least tweak some of the stuff that's in this article, because it is scary that the problems are still there. But I think we're trying to tackle them, since the societal norms aren't things we can just change overnight.
Right. I appreciate the question. I think one of the things that, I think we should acknowledge just at the outset is that I think the system remains and sustains itself really on the backs of kind of the selfish individuals that really are showing up at work, doing the hard work every day. Right. And I think when we think about sort of the next steps and how can we make things better, I think some of the things we need to think about, right, are how do we augment exactly what you're saying? How do you augment those clinicians, those nurses to be a little bit more efficient, or a little bit more, to really free them up to have more time to do the human part of medicine. And so, one of the things that we're exploring, and I think a lot of systems are really looking at, and this is certainly moving pretty fast, right? So AI scribes. So the ability to basically take your phone and walk into the room, let it listen to the conversation that you have with the patient, and really build the whole note from there. I think I wouldn't be the only clinician to say this, is that none of us like to sit there and document, right? It takes time away from the job that we really want to do. And at the end of the day, the ability to sort of pull that away and allow that note to be built prior to any physician involvement is fantastic. I think where you'll see it go from there, and where I really think you'll start to make impact. So that's great. And I think saving clinicians time there, helpful. But I think you'll start to see the next steps, which are really clinical decision support. So that the AI running in the background, listening to what the physician's saying, but then also incorporating the labs that are coming back and pulling that in and saying, okay, here's some thoughts about the clinical diagnosis that you should potentially work on. I think that's probably coming in the next 3 to 5 years. If I had, and maybe even faster. There's probably systems that are already kind of trialing tools like this. And I think obviously that technology will have to come with some guardrails, and you'll have to think about sort of all the implications of incorporating that. But I think it's coming, and I think that will be an additional. I think that will be a real value add to patients, right? I mean, for instance, there are plenty of times in a clinical shift where there's a diagnosis maybe that I should consider that a system could nudge me and say, hey, did you think about this? And here's why. And I think that would be awesome for clinicians. I think that I would say the counter to that, and one concern I have is, I get concerned that you're going to start to see a dichotomy in the system, the availability of those resources. So your systems that have the resources to deploy those technologies are going to be at a significant advantage over, say, the rural systems that support patients out, in the communities that they live in. And they may not have access to those tools. And so you're going to start to see sort of a wider and wider gap in the care that's delivered to those organizations. And so that, again, I think that's a societal issue that we'll have to address along the way. These types of tools should not be just available to just the highest bidder. I'd say we should allow that they should be there for the benefit of patients going forward.
Yeah, I think that piece is obviously very important to make sure that everybody is getting access, but there's also the piece of errors, right? And protecting the patient and misdiagnosis and becoming overly reliant on it, right? And we can see memes or different things that are out there, and people talk about this great idea that you can replace let's say a radiologist. They can do all the reads through AI and blah blah blah, right? The reality at the end of the day is we still need the human intervention to deal with the error rates or complications that can show up. There's wonderful things that can be caught, but as a clinician, as a physician over the last 20 plus years, I'm sure that's a big concern too, because it's great to get the nudge, but how do we balance the excitement of the technology helping people using it as an incubator or trying it with kind of not malpractice, but misdiagnosis and down the line challenges are going to come from that. That's the one thing I don't hear talked about quite as much.
Well, and I think that's, I think look, I'm not a technologist, but I do think like the ethos in technology, right, is like, you've heard this, like, move fast and break things. Really push something out before maybe it's ready for prime time. And I think that ultimately that is something that clinicians and hospital administrators will have to decide sort of where the comfort level. We're going to have to look at these resources, and just like we do with any other bad outcome, or we're going to have to investigate it, right? Why did the system do X, Y, and Z? And the systems will probably have to run in the background for a little while, and sort of where we can really assess, are they really a value add to the clinicians, or are they creating problems? And I don't think we'll know that immediately. The other piece to this, Trevor, that I think is also interesting, you really get into it, is, medicine has been, I think, fairly slow to adopt technologies in some areas, right? I mean, we're still using the fax machine. I mean, how insane is that, right? I mean, just to go back to sort of care being delivered 35 years ago. I mean, some medical records still need to be faxed, and that's, I mean, so I think care delivery or the technology is moving faster probably than medicine is maybe ready for, and so I think we're going to have to really sit down and think as sort of a healthcare society and say, hey, this stuff is coming fast. How are we going to deploy it safely for our patients?
Yeah, I mean, it harkens back to some other discussions that I've had. I remember a nurse leader I talked to that their system was trying to implement a new AI tool. No nurse had ever seen it. And there was no discussion about the implications of what was going to happen day to day for them. And so, that also leads us, and it might be a good place for us to kind of dive into next, is that clinical workforce of the future. Like, yes, you have to have the medical training. Yes, you have to have the compassion. Yes, you have to be a selfless individual at heart. Otherwise, you're going to go into the tech sector or pharmaceuticals or something else, right? But end of the day, do you feel that our physician community and our clinical workforce in general in the future is going to look different than it does today in regard to whether it's the day-to-day, their training, their expertise, the things that they'll be, focusing on?
A great question. And I think the answer is yes. I think when you really think about the skills that will be needed in the future, I don't need to memorize the Krebs cycle because you can put it into Chat GPT, right, and get the answer to that very quickly now. So I think the ability to acquire information, it will be at your fingertips instantly. That's not something that I think clinicians 34 years ago had the access to. You really had to know all of those things. Now, I think you still need to know that, or you need to know how to apply it, but you may not need to memorize a specific formula quite like you once did. So I think what that really all sort of translates to me and sort of goes back to, I think, healthcare being hard and humans, taking care of humans, which is, I think the soft skills, the communication pieces, the ability to influence patients and get them to pursue primary care, preventive care treatments. I think that's where the real value add is going to come in medicine, because I think you're going to see the workforce of the future really needs to be almost more empathetic and understanding and have better communication skills. Because I also think the pipeline of data coming into patients is just, there's more and more. I mean, people are using wearables, and, I get people that show up in the ER now that are like, hey, I think I was in AFib, and their watch, and so there are a lot of, I think, avenues that clinicians need to be ready for. But I really think it's going to come down to continuing to train clinicians on soft skills, communication, being able to really relate to patients, and then use all of the information that's coming in and the tools that you have, and apply it appropriately. And so I do think that is going to change the workforce of the future over time.
Yeah, well, it's changing it, but it's also harkening back to the really important side of medicine, which is those soft skills. Right. It is the human interaction, right? It's kind of like as much as things change, sometimes we have to go backwards, and we need to focus on the very simple things first. And that's right. It's not easy to, in knowing physicians, over my last 18 years in the career and working with you all, the level of empathy and the things that you guys have to deal with on a day-to-day is not what I guess I'll just say average person can deal with and compartmentalize and manage. So it's an extremely difficult thing for us to do, but I like hearing the fact that it's also important to focus on the soft side. It's not just about technology, et cetera. So with that said, you've seen it from a lot of different areas, right? So whether it was when you were in your residency or leading residents or, throughout the rest of your training and into your career, what has you excited about the future of medicine? Is it the clinical innovations? Is it people and growing, the workforce and the people that are doing things differently? Is it operationally? Like, what has you very excited for the next, say, 5 to 10 years?
Yeah, honestly, I think it's the people, right?
Okay.
I mean, the same individuals that have selflessly gone into medicine for those initial reasons are still going to go into medicine. But I think my hope is that there will be more tools to let them do the things that they're good at, and not spend as much time doing things that maybe aren't as relevant to care. And I think we actually talked about this with one of your other guests, Lee, which is Lee Hamby. Each time we've had, I think clinicians are a little leery of the fact that each time there's a new technology sort of inserted into healthcare, everyone is like, oh, it's going to make life so much easier. But the reality of what happened with the electronic medical record is it hasn't necessarily made life easier for clinicians. And I think a lot of clinicians would be very frank and say that. But my hope is that AI is, and sort of the technology that we're seeing come along now is different. Because I still think that the people that are interested and want to do and help other people, that's the piece that has me the most excited. We've got great clinicians in our, within our organization that go to work and do amazing things every day. And so that, that keeps me going, keeps me excited.
Well, that's great. We need more physicians like you. We need more organizations like yours that are driving the right mission out there. And so I think we'll wrap it there today. I really appreciate you, joining us, sharing some of your wisdom. Again, it's been an absolute pleasure getting to know you, and looking forward to our continued conversations.
Awesome, Trevor. I really appreciate it. Thanks for letting me chat.
Thanks so much, Josh. Hey, everyone. Hope you enjoyed our discussion today with Josh. A lot of great insights shared. And please join us for future upcoming episodes with additional leaders and innovators from across healthcare. HWL Talks is excited to have you join us, and we look forward to seeing you in the future.